the MRI. So what do you think? Which one is superior, CT or MRI?
I think for students as well as for all of us, the investigation of choice is a CT scan. HRCT is the investigation that we need to do for cholesteatoma evaluation, surgical planning. Role of MRI, diffusion weighted images come into play if you have done a canal wall up procedure or if you've done mastectomy with cavity obliteration, where you cannot examine the cavity for possible recurrence of cholesteatoma. In those situations, if you want to follow them up, instead of doing what used to be a second look operation, you can do diffusion weighted MRI.
Right.
So for surgical planning, MRI is not, the MRI is only used in certain situations, like if you suspect recurrence and there are a lot of granulations and the cavity is full, you don't know whether it's cholesteatoma or something else. For hidden areas, you can use MRI in revision cases. But primary investigation for, I think, is a standard HRCT.
If you are operating surgeon, CT scan is extremely helpful. It is very difficult to take bony information from the MRI. If you are planning for surgery, the good choice is CT scan. Regarding the consent, so we are interested to know how you counsel your patients that you are planning to do the modified radical mastectomy, or you consent, take the consent from the patient.
I think it's ignored area, and I think it's a balance that you have to achieve, because this surgery has potentially a lot of serious complications.
Right.
The possible complications of facial nerve damage, dead ear, damage to the dura and CSF lead. These labyrinthitis, these are serious complications. So if you tell that patient the possibility of all these things, then I think a lot of patients would choose not to have the surgery done.
Right.
So therefore, your counseling has to be very informed counseling. You have to give them some statistical data that this is the possibility of a facial nerve damage, whether it's going to be, most likely it's going to be temporary, it recovers if it happens. Similarly, the risk of dead ear, whatever it is, 1% or whatever, but that's an experience set. But at the same time, you also have to tell them that the cholesteatoma in itself is likely to give you more damage and complications if you don't get it done. Right. It's just like counseling a patient for laryngitis. Although it may look very, very grave to the patient that this can happen and this can happen, but you have to tell them the other side of the story as well. And in informed consent, I think we must give them some data, some percentages that this is the possibility of 2-3 things I think we must list in consent form. The facial risk of facial nerve, but the only trouble is that the statistic data that you available comes from very experienced centers.
Sir.
So if you're talking about a guy who's a experienced otologist says the risk is 1